want to thank everybody for participating in our webinar, and I'm going to turn it over to Dr. Rhonda Henry Tillman to provide welcome from the section. Dr. Henry Tillman is the section chair for the surgical section of the National Medical Association. Dr. Henry Tillman, please go ahead.
Good evening. As chair of your surgical section, I'd like to welcome you to our webinar this evening, Medical Students in Residency, Training in the Era of COVID-19, What Have We Learned? And also notes and speaking from Dr. Cornwell and our historical Black universities. And I would like to turn it over to Dr. Joseph.
Thank you, Dr. Henry Tillman. My name is Kim Joseph. I'm the Executive Director for the Surgical Section, and I'd like to welcome Dr. Henry Tillman's, I'd like to echo Dr. Henry Tillman's welcome to everyone. As she mentioned, this webinar is going to focus on the effects of COVID on our training processes for our medical students and residents. We have three speakers who I'm going to introduce in just a moment. All of them are representing the historically Black medical institutions. And in addition to that, we have a featured speaker, Dr. Edward Cornwell from Howard University, who is a longtime section member and a past chair of the section. Many of you are aware that he will be stepping down from the chair position at Howard this year, and he will give his perspective on the future of the section during these tumultuous times. Before we get started, I just want to extend special thanks to two people, to Jordan Licata, who is our technical expert, as well as the webinar website support person for us in the section. Thank you, Jordan. And also to Ms. Rhonda Smith, who is our section administrator. As far as some housekeeping things, everyone is going to be muted other than the speakers. At the end of the third talk, we will have a 20-minute Q&A. You can submit any questions you have via the chat function, and this can be done anytime throughout the program. As I said, we'll have that 20-minute Q&A after the first three speakers, and then I also do want to let you know that the program is going to be recorded, and we will have information regarding that towards the end of the program. It'll be available on our website. So let me introduce the first of our three speakers. If you go to the next slide, Jordan. So Dr. Carlton Adams, who, as you see, is the chair of the Department of Surgery at Meharry Medical College. Dr. Adams received his MD degree from Howard University College of Medicine and completed his residency at Meharry. He was the first vascular surgery fellow at the State University of New York at Buffalo. He is currently the chair of the Department of Surgery, as you see, as well as the chief of the Division of Peripheral Vascular Surgery and the chief of General Surgery at the Nashville General Hospital at Meharry. He's the senior clerkship director for the Meharry surgery program, and he will be sharing with us the experience, how COVID has affected training at Meharry. He'll be followed, next slide, Jordan, by Dr. Ella B. Washington, who, like myself, is a graduate of Columbia University College of Physicians and Surgeons in New York. He then did his residencies in general and orthopedic surgery at the St. Luke's Roosevelt surgical programs in New York, as well as a pediatric orthopedic fellowship at the Hospital for Special Surgery. He's currently the professor and chairman of the Department of Surgery at the Charles Drew University of Medicine and Science, as well as a professor of clinical orthopedic surgery at UCLA. He is the lead physician and director of orthopedic surgery of the orthopedic surgery services, both at the King Outpatient Center and at the King Community Hospital. Our third speaker, next slide, Jordan, will be Dr. Erica Sutton. Dr. Sutton received her MD degree from the Johns Hopkins University and did her surgical residency and her MIS fellowships at the University of Maryland Hospital System. She is the president and founder of a very innovative program called Surgery on Sunday in Louisville, Kentucky, where she arranged for people who were either uninsured or underinsured to get access to surgical care outside of normal business hours. And after having done her stint at that program in Kentucky, she moved to Atlanta, where she was named the Associate Dean for Academic Programs and Affiliations at the Morehouse University School of Medicine. I'm going to introduce Dr. Cornwell later after the Q&A, so let's proceed now with Dr. Carlton Adams from Meharry. And he will be, you can share your slides, share your screen now, Dr. Adams.
Thank you. Good evening. Thank you, Dr. Joseph, Dr. Tillman, for the opportunity to present here, and I'm certainly honored to discuss with one of my former schoolmates, Dr. Cornwell, about the difficulties and the opportunities that we're having currently throughout the nation. Meharry Medical College has long been established as one of the leading historically Black colleges for training of medical students and residencies. Since the 1992, however, Meharry's residency program in surgery was disbanded, but we have continued to provide resources to training programs throughout the country, as well as to the other historically Black colleges that train residents. So I've decided to restrict my comments to medical student training and what we have learned here at Meharry and how we're moving forward with our curriculum. During the time that I was faculty, Meharry has managed to maintain its accreditation in all of its medical school graduate programs, as well as the existing residency programs that they have in internal medicine, OBGYN, and family medicine. During the conduct of our accreditation, one of the LCME recommendations was for this college to increase its school size, and we have progressively done that through the years. We continue to get a large number of applications, and this year is going to be one of those interesting times because we won't be doing our applications face-to-face. It does allow for us as faculty to have a little more time to concentrate on training of students and residents. What you see here is one of the newer buildings on campus. For those who are familiar with the campus, this is the Cal Turner Family Center. And one of the features of Meharry that I think is interesting is that most of the buildings have been named for individuals during their legacy. They didn't have to die to get the building named after them. They just had to do something significant. And many of those individuals I've come to know and respect. We have currently 3 campus locations for rotations. We have our national campus, in which a number of partnerships, institutions have helped us with the residency, with the student training. We have a hospital on the campus that is the county's city-owned public hospital, National General Hospital at Meharry, which relocated from its original location to Meharry in 1995. We also have an affiliation with the Nashville VA, which shares its campus with Vanderbilt. And we also have students able to rotate on subspecialty rotations in surgery at Vanderbilt, as well as the HCA campus in Southern Hills in the southern part of Tennessee. 2 of our bigger partnerships recently that have occurred over the last few years. One is in Michigan, Detroit Medical Center at Sinai Grace, in which alumni from Meharry and Howard in surgery met through a meeting, alumni meeting, with a former dean, Marquetta Faulkner, and began a discussion about having students rotate through here as a means of trying to give back, but also trying to encourage and mentor some students and candidates into surgery, with the idea that some of them might be interested in coming back to Detroit to continue their practice careers with them. And along that same time, University of Alabama, Birmingham also established a relationship with us as well for student rotations. You can see here the number of students through the 2019-2020 academic year. And this was actually the census before I came back as chair. I came back as chair of the Tennessee shutdown, or Davidson County shutdown, at which time we had all these rotations set up. We were able to restart our programs with Detroit increasing the allocation of students that they could train, and at the same time, some of the partnerships, affiliations that we had, restricting the allotment of students coming, largely because their campuses remain closed. When we restarted the program, I came back in the middle of our getting ready to start, and there were a number of questions that we really had to think through and decide what we're going to do, because a large part of our training was face-to-face. We didn't use a lot of technology. We did use some, but we didn't rely on technology, and it made for difficulties in terms of keeping on time with schedules and making sure that everybody was where they're supposed to be. Rotations where we had students on campus that had to depart from those rotations and rejoin us on campus for lectures. Often both they were complaints from the faculty as well as students. In order to really make these changes, we really needed a skilled coordinator to organize the schedules, to manage the technology, and to coordinate with the partners on what we needed to have as far as curriculums going forward. And I was fortunate in that that individual was already there when I got there. And she was able to manage schedules that fluctuated week to week, from affiliation allotments that opened up and closed just as fast. All of those things were occurring without regard to what was actually really happening clinically. Pretty much in late July, we were able to be back operating fully with elective schedules. So we were able to have an opportunity for students to gain their experiences. What the school decided at that time was to start the students through elective senior rotations. So they were doing that during the shutdown. And for the surgery rotation, the way the schedule had been set up, the students had stopped their clerkship in the middle of the rotation, about 6 weeks. Our clerkship was designed at that time to be a 12-week rotation. We also needed a willing clerkship director. When I came on, the clerkship director was leaving, and I couldn't convince him to stay, and that left us with less faculty, but also with a responsibility to kind of make sure that continuing academic goals went forward. And so I decided that at this point in time, rather than appoint one of the other faculty members, that I would take on that responsibility and work with the clerkship coordinator, the dean's office, and the students to try to redesign the curriculum so that we could continue to take care of patients and move forward. What we were determined to do was not say we couldn't do it, but say that we could do it with the technology, that we could do it remotely, that we could do it with our academic computing department, and make sure that the students had an opportunity to kind of stay at their sites. We did that by meeting with the faculty and telling them that they were going to start doing all of their lectures as a remote schedule. That meant that if they were just about ready to do a operation, if they could hold on for 30 minutes, they could do their lecture from their smartphone or from the desktop where they were located, or they could come back to their office. But we worked out that arrangement through the system using the Blackboard academic computing system, as well as through Zoom sessions. That worked well for the students because they didn't have to leave where they were for their rotations. And we were able to also record all the lectures so that if in fact somebody was pulled away for emergency, we could still give the lecture as a recorded lecture. as some of you may have done this, you may understand that with this technology and what we're doing now, individuals aren't always seen by their face or either heard by their comments. It was much more difficult to get student interaction. And in the midst of this, what we decided to add to this process was to require poll questions to be included in the lecture, and the students record their answers so that we could build a dialogue with them as we're instructing them. Almost everyone had the equipment and technology, but the dean's office was able to get a grant so that we could increase the desktops and access in the office. Students already were using their own laptops, but we were anticipating the possibility of needing to have extra space within the office where students could be in smaller groups and socially distanced. What we found is that wasn't really necessary. We just actually allowed the students to log in wherever they were located, and as long as they had good internet access, things worked pretty well. The other thing that we're required to do for a successful start was to have more elective fourth-year rotations. When the AA and C recommended that students not leave their state of origin during their academic year, we were not really fully prepared to accommodate that. Neither was Vanderbilt and many of the other institutions, because normally we recommend our students to travel to prospective sites and display their capacity and increase their opportunity for residency matching. So we had to develop some additional surgery senior electives. I had an elective in vascular surgery that usually was supposed to be one student at a time, wound up being about 5 students at a time, which became a unique challenge for me. But we were able to satisfy all the students who were fourth years needs through our partnerships with Vanderbilt and the neighboring communities within the state. We worked with the dean's office to arrange for those situations, and we did add some additional surgical electives during that time. The key aspect of this was a coordination between the dean's office and the clerkship coordinators. Without that, we would have really had a lot of problems with students in terms of being able to keep track of how they were progressing through the clerkship with their independent study plans and with their preparation for testing. We have long had a standard for all the clerkships to require passage of NET standardized MBME subject board examination. And at that time, just before that, students were having some struggles on the bottom aspect of our group trying to get through those exams. If they don't pass them on the first time, we were requiring that they remediate during another clerkship period within that same year. And if they did not successfully pass it, then they were required to repeat the clerkship. So we set about a task of trying to see if we could maintain or increase the performances on those standardized exams, and to provide a means for testing for the students, which, in a traditional sense required us to be, monitoring them through the exams. And we have progressed to the point where we actually do have some remote testing situations where we use virtual monitoring capacity and locking out the web access when the students are taking standardized exams. The biggest problem that we've had so far is being able to kind of still connect with students face on. It's a lot different to maintain a relationship with the students and to encourage their academic clinical effort and their physical work effort, when a large part of what they were doing was remote or limited hospital-based activity. But many of the students have been successful in demonstrating their improvement of skills. We have been able to actually increase the number of responses we get from faculty evaluations. And we've also increased the number of adjunct faculty in our department. With regard to the standardized testing examinations, we were able to take the class that had only done 6 weeks, and through a new integrated technological rotation, we were able to have them successfully, all but one, pass the standardized exam. And that person has been able to successfully remediate through the next rotation. And we have actually increased the mean score on the subject board approximately 15% from where we were before. So we're continuing to monitor that progress and continuing to try to revise things on the fly. One of the things we're trying to revise on the fly is our skills lab situation, where we're trying to do those in small groups now, but we're looking at this rotation and trying to do some virtual instruction. And we're going to start out with the endotracheal intubation skill test, as well as knot tying and suture tying to be done through a connection of virtual instruction, where we'll be close by, but we're requiring the students to first view some instructional videos, and then we'll have them with their laptops and their skill devices. We'll be monitoring those who can do the skill and pass them through as quickly as we can, and those that we need to spend more time on, we'll spend more time on. And so we're going to look at how that process works through. And I'm glad to hear that Dr. Sutton is here, because she may need to help me with that, a little bit of that. I know she has experience with it. Through this time, what's been encouraging to me is that we've had a lot of calls from faculty, former faculty, alumni, and even just interested parties that are interested in being mentors and having students rotate in their practices remotely. So we hope that we'll be able to also advance some of our senior electives to accommodate that. And in some cases, we may be expanding our third-year clerkship to some of these partners. Let's see. How am I doing on time? Let's see. Okay. Looks like I'm okay. We also had an issue with attrition as a risk for us. We wanted to make sure that we didn't lose any faculty more, because if we did, we really would be hampered as far as our core teaching faculty. We currently have about 4 core teaching faculty members, and with the pandemic, we did experience a 6% salary reduction, and we were able to manage that, delay it as far as we possibly could into October of this year for its implementation. And we hope that once we have continued to increase our clinical activity, that there's a probability that we'll have some of that recouped towards the end of the budget cycle. Our biggest risk was to our academic support staff. And we decided at that time to actually find some other resources that were restricted funds that could be used to offset the across the board reduction for those individuals. We're fortunate that the finance department did accept those. And so we've actually been able to use that as a demonstration to our support staff of how valuable they are to us. And we really couldn't do this without them. This picture you see on this slide here is one of our newest endeavors. The city had established 2 testing centers during the initial shutdown. And Meharry started one on our campus as well through using their own resources. Towards the end of that time, they were able to negotiate with the city to contract for the staffing of the 3 citywide public testing centers throughout the city. And we continue to do that to this day, even through the temperature changes that we're experiencing now. And on one of the pictures, you may see that in between 2 of the buildings is what looks like a tent in the middle of the street. And what we did establish with the Army Corps of Engineers, the tents the size of a street that cars could drive through and be tested, and the workers could seek some shelter. And they're currently using some heat blowers and devices to try to keep them a little bit warm during the time. The testing time that we do for this is from 8 to 2 o'clock daily, Monday through Friday. Meharry also runs voluntary testing sites through a number of neighboring historically Black churches on Saturdays. The biggest also importance was that we were able to use the Zoom and the Blackboard technology to actually meet with our partners. Those cities are fairly remote, and I've only been able to go to Detroit during the time that I was here as a junior faculty and survey their institution. But I was able to actually meet with the new acting program director and the clerkship coordinator at University of Alabama, Birmingham. And through that conversation, we established a link with their Grand Rounds program, which they had begun to start as a virtual program. So we were able to link into those programs, and we utilized that for the students on Tuesday mornings. And after that, we have a post Grand Rounds discussion with them using our academic Blackboard. We're looking at also doing that with the Detroit Medical Campus, trying to link up with their mortality and morbidity or their residence teaching conference as well. And what we do is we have the students who are not at those campuses, but at Nashville, link into those programs. So with that, without talking any more about any of the financial details, we were able to get full support for these things. We're working now with our budget projections for next year. We're anticipating that the budget for all the PPE materials that we were supplying to the hospital for students to be able to roll back into their facilities will be part of our budget. But the biggest thing that we're most happy with and proudest of is our newest collaborating partners. That wouldn't have been possible without the enthusiasm and support of Dr. Herbert Chin and Dr. Selwyn Vickers at University of Alabama, Birmingham, and Dr. John Whitaker and Dr. John Barnwell at the DMC Sinai Grace Hospital. Thank you.
Thank you, Dr. Adams. We really appreciate your taking the time and to describe all the challenges that you've been facing at Meharry. Our next speaker is going to be Dr. Washington. And Dr. Washington, if you want to start sharing your slides. And just a reminder to all the attendees, you can submit chat questions at any time during the program, and we will try to make sure that as many of them get answered by our speakers as possible. And Dr. Washington, you're still muted.
All right, can you hear me now?
Yes, sir.
Okay, thank you very much. Well, good evening or good afternoon, depending on where you are. Greetings from Southern California and the Charles R. Drew University. I'd like to thank Dr. Joseph for inviting me to participate in this webinar with these other outstanding surgeons. I'd like to congratulate Dr. Cornwell on his award for distinguished career and outstanding service to the surgical section of the NMA. Now, I bring greetings from my general surgery faculty colleagues at Drew, including Dr. Maxine Anderson, Sheila Clayton, Gracie Dinkins, Anthony McLeod, Ryan Hubbard, Jean-Claude Henry, Gudata Henneke, and our emeritus professor and chair, Dr. Arthur Fleming, to name part of our department. Now, while it's clear in this era of COVID that we must continue to produce an outstanding, highly competent emerging physician and surgeon workforce, we're all quite aware that our number one priority is the safety of our patients, our trainees, ourselves, and members of our team. Now, as we look at the domains of medical student and surgical residency training activities that you see on the screen, we're now aware that some of these domains lend themselves more easily to the successful continuation of surgical training virtually, while others not so much. So to remain successful in producing the desired outcome to essentially replicate ourselves, we have had to re-examine and essentially change how we've been doing business to some degree. Now, we can see and we have found that in the selection and examination domains, they tend to lend themselves more easily to virtual platforms for evaluation and in some cases education. At Drew, we are selecting both our incoming medical student and resident class after online interviewing and data evaluation. Now, the assessment domain continues to require some in-person contact, modeling, teaching, coaching, mentoring, but even in this domain, we can use more virtual meetings. The education domain can use a lot of virtual platform. Now, in regards to medical student surgical, resident and medical student surgical experience, we know that this predominantly will come from an elective caseload. We have seen our elective caseload diminish to varying degrees, especially during the COVID spikes. It is noteworthy that our evaluation and accrediting bodies have taken note of this, and it's my understanding that they will require 10% less surgical cases for the 2020 training year, both the American Board of Orthopedic Surgery and ACS. Now, the lessened availability of elective case has brought back another issue front and center, the old debate of time-based completion of surgical requirements versus competency-based. And we've had to consider whether we can financially, as institution, support training, extensions, and delayed completion of requirements as we're supposed to. Finances are tight in the era of COVID. Now, the didactic part of the educational process in many circumstances can once again lend itself well to distance learning and virtual platforms. Robotic training, however, is one area of exception, and training in on-hands activities we found very hard to do virtually. Now, patient care, however, as they say, is where the rubber meets the road. The whole patient care team is made up of individuals with different levels of education and training, And while the larger the group, the harder it is to keep everyone safe and COVID-free. However, in some of the residency programs, we have employed the strategy of taking them out of individual rotations and putting them into larger groups that are isolated from each other, just in case we have an outbreak of COVID in one of the groups. And that group has to be completely quarantined or isolated. Now, in regards to direct in-person patient contact activities, in order to keep everyone as safe as possible, we rely on the attending faculty member to actually police behavior and continuously monitor, teach, and instruct both residents and medical students in the proper PPE usage, including donning and doffing, and safety habits in general. Now, we employ screening systems for patients before they're surgically evaluated, before they come into our clinics. We triage severity of condition and potential or real COVID positivity. We have tents outside of our hospital and outside of our clinics where we evaluate the patients before they come in and do pre-screening. At some points, both the residents and the medical students, if desired, and if they were at a certain level, have actually participated in the screening activities, as we all have been out in the tents. So now we also standardly use a buddy system for the medical students and the resident mix, both in the clinic and in surgery. And what we do is we have the buddy examine his buddy, and then they turn it around. We've also used the double mirror technique so that you can look at yourself before you go into the patient contact areas or into the OR. And these have helped us and worked quite well. Interestingly enough, I have found that the younger medical students and earlier residents are not as afraid of COVID as I am for some reason. And I have to be on them continuously about wearing their PPE. I guess they're not really afraid of dying the way I am. Now, this is me giving a demonstration. Now, at Drew, as probably most of our institutions, we have a highly integrated educational medical program with multiple partners where medical students and residents are training. The rules and regulations in regards to safety measures actually differ slightly between some of the institutions, but we have a bunch of them. There are the alphabet accrediting bodies which put out standards, but the final authority rests for protection and decisions in regards to the medical students and residents in the dean of the medical school, and for the residents in the program directors and the DIO. Now, additionally, we as managers, in addition to being surgeons, are now more than ever, we have to be aware of resident physical and psychological medical states. We are all handling the stress of job, education, and COVID differently. Now, to this end, we should have complete evaluation and medical care support system available for our trainees more than ever before. That should be easy for them to access. And we should make it clear to them that it is not something that we hold against them when they need to get help. We also need easy access to testing. We need ongoing, we need easy access to resources when somebody's isolated. That's hotel stays that are paid for actually not by the residents, but by the institution. And in this time of COVID, it's been hard to find the monies, but we've been able to get some money from, donated money from various sources to do these things. Additionally, we also have to keep an idea on support for the families and or the significant others, because a lot of them are having a hard time when their significant others come home or may be sick and in isolation. And the last thing we need to do is have good contact tracing capability so that if one of those groups gets sick, we can find everybody else who's been in contact with that resident or medical student to try to prevent it from going further. Now, we also need to understand that there are other issues which can affect the lives of our medical students and residents, as well as ourselves. This picture is of a resident medical student-led demonstration for White Coats for Black Lives Matter outside our university. It was important enough to them to take the risk of social gathering, and they dragged some of us attendings along with them. We did our best to stay safe. Now, finally, we have to now begin to consider how we will shape the future of medical student surgical resident education as the vaccine becomes nearer. Will we, can we, or should we go back to where we were pre-COVID, or have we been enlightened that there may be a better way to do things? I think we're going to have to decide as groups how we're going to do this. Thank you very much, and we'll take questions at the end.
Thank you, Dr. Washington. I think there are definitely some themes emerging here that we'll get to with the Q&A. And congratulations on being able to keep your trainees both medically and socially involved in a safe way. I'm going to turn it over to Dr. Erica Sutton, who will be our third speaker from Morehouse, and she's already got her slides up, so I'm going to be quiet now. You're still muted, Erica.
Okay, I said I'll finish before 8 so that we can be sure to have some Q&A. So first of all, from Morehouse School of Medicine, and on behalf of my chair, Dr. Ed Childs, and our program director, Dr. Shanita Johnson, who is on the call tonight, I just want to say thank you for the opportunity to talk about what we've learned from the pandemic and what we've loved about 2020. And these are the aspects that we think should endure as we all recover and survive this pandemic. Okay, so we learned that doctors are essential. And this is Drs. Redfield, Hahn, and Fauci from CDC, US Department of Health and Security, and FDA. And what I really wanted to point out was here in this phrase, I highlighted in blue, they provide the guidance that we have continued to use in multiple settings across the pandemic to how to keep yourself safe. So you have to continually show evidence and then look for the following evidence: that people are asymptomatic, that they are being screened for fever and symptoms. And we've seen a shift in the symptoms away from fever toward loss of taste, toward other symptoms, wear face coverings, and maintain a social distance of 6 feet. And these were the conditions under which in May they said they would participate in in-person White House briefings. But we loved being acknowledged as heroes, as healthcare providers. And this gratitude, I think, certainly want to carry forward with us in 2021 in acknowledging both the risk, the passion, the effort that healthcare providers are putting forward in the pandemic, but really we know as effort that's put forth every day. We learned that being safe required creativity, teamwork, a lot of discipline. This is from our holiday campaign at Morehouse School of Medicine that encouraged people to change their traditions to stop transmission. And so we have the hashtag Mask Up and a public service announcement that aired on YouTube called Keep Your Bleep at Home, targeted toward the under 30 audience, but really putting out the message that in order to stay safe, we were going to have to really change what we were doing, even some of the things that we value. We also had to form definitely some partnerships. We returned to the campus environment in May of 2020. And to do that, we formed a partnership with Color. And Color provides our COVID-19 testing on a schedule of 7 to 10 days per policy. We can't go outside of 14 days to be present in our learning and work environments. We have recently been able to offer this testing to family and friends for $50. This is about $89 cheaper than what you can get at CVS. Most communities do have free testing, and of course, we make all of our family aware of that. But sometimes that also involves a wait or the timing of that, and return tests can be difficult. So we do offer this option to our friends and family of Morehouse School of Medicine to get tested. And we loved virtual interviews. I think in the chat, someone referenced the article that came out that I saw today, advertised in the bulletin from Drs. Wiegelstein and Levin about is it too late? It may be too late to save the surgery match. What we loved about virtual interviews is its decreased cost, the decreased time for applicants, and that can level the playing field for applicants that may have different resources to travel and to attend these interviews. There's an increased availability of both the applicants and the faculty that we've observed. The downsides include some of those, most notably in the article, is that programs are interviewing the same roughly 100 to 200 students, that it's the same applicants that are getting multiple interviews. And there's guidance provided in that article about really peer etiquette to ensure the availability of applications across the board. I have to say we've seen some benefits to this also for undergraduate students applying into our medical school, and the fact that we've been able to interview more applicants and really address, I think, some disparity in financial resource. It's why we love the virtual interviews, and I highly suspect that we will continue to offer virtual interviews even after we feel that we are safe again from COVID-19. We learned that the research experiences for our graduate graduate medicine and educational biosciences program, graduate education biosciences, were vulnerable to disruption. These researchers need daily access to their labs and to their projects. And just an every other day work strategy wasn't sufficient to keep these grants and these scientists at work. And so we definitely had to work and innovate our protocols around the research environment. Really, quite devastatingly, we found that student experiences in the lab were frequently canceled or disrupted. And students use these both for career development, to understand what type of surgeon scientist they want to be, and to boost their applications. We really found that there was a lot of downstream impact to the altered research environment that we experienced. But out of that, we loved community engagement in research. And at Morehouse School of Medicine, we are #1 in social mission in the country. And we found ample opportunities to engage in community engaged research, certainly around COVID-19, most notably with our $40 million HRSA grant that you'll see, but also with a grant from the Gates Foundation to offer additional testing. And additional partnerships now surrounding the COVID vaccine development that is underway. And other ways in which it's impacted, there were multiple $1 million, $1.5 million grants to the researchers at our institution. And so we have to say that going forward, we've used this opportunity to recognize that community engaged research it should certainly endure past this pandemic. And then for our students, we loved creating a scribe program. About a year ago, I worked on the same project and got crickets and not a lot of engagement and not a lot of partners. And then subsequently, we've been able to engage 2 companies in developing a scribe training program for our learners and for students who are interested in gaining clinical experience and participating in the ways that they can. They include virtual or telehealth training so that students can participate remotely as scribes, as medical scribes. And so we're really proud of these two partnerships that we've been able to innovate, since the pandemic. At MSM, we learn the importance of diversity and inclusion training, even at our historically Black colleges and universities. While the typical ideas around D&I, they apply differently for us. I think at HBCUs, at PWIs, oftentimes they just want to know, do you have enough people of color? Do you have people of color in administrative positions? And certainly that isn't precisely the question that we learn to ask. And we learn to ask, do we have a true diversity, not just ethnic diversity at our institution, but gender, sexual identity orientation? Do we have diversity in people who come from rural areas, medically underserved areas, geographic diversity to our student body and to our faculty and staff? And so really we are in the middle of a search for a chief diversity and inclusion officer. And what is, I think, an effort to really lead HBCUs in ensuring that we too are monitoring our inclusivity in our learning environment. And lastly, we loved being valued for what we bring to healthcare. This was really a high point, I think, for our school this year when Bloomberg Philanthropies invested in our students and sought to help relieve some of the debt that our medical students faced. And so we certainly appreciated that recognition and what we are bringing in, the healthcare workers that we are adding to the workforce. So the enduring lessons that we have from 2020, it's appreciation for our healthcare workforce, virtual interviews that do save resources and level the playing field for applicants, in community engaged research, our scribe program, and valuing diversity and inclusion as we define it and need it. Thank you very much from Morehouse School of Medicine, and on behalf of Drs. Childs and Johnson. Take any questions.
Thank you, Dr. Sutton. And please thank you to all of our speakers, Dr. Adams and Dr. Washington and Dr. Sutton. We are going to take some time now to do some Q&A. And I have, as I've been watching the chat and just listening to the presentations, there definitely are some themes that have emerged. And one of them that seems to come up is the issue of the well-being and wellness for our trainees. And Dr. Washington mentioned it in his presentation. It was also alluded to in the other presentations. Everyone has sort of alluded to the fact that there are resources available. So as a former social worker, what I want to ask the three of you to maybe address is, first, is there anything happening where you are proactively looking to see if someone is having trouble from a mental health standpoint? And secondly, one of the things that came up in the chat was, and in Dr. Sutton's presentation, this notion of now we are being identified as heroes. That's nice, but is it potentially dangerous in terms of expectations? So maybe start with Dr. Sutton.
So we recognize the need to reach out, particularly to our first year class. They finished college, hit a pandemic, and they started medical school in a pandemic. And in our learning communities, which has two faculty mentors, and it's often a slightly less structured setting, I would say, so that students really have the opportunity to talk. We recognize that they were feeling disconnected, sometimes from, largely from one another, but absolutely from faculty. And as faculty, our perception was, well, we meet with you, but we really are looking at them in this format. One person speaking in Hollywood squares of students, and that wasn't the level of connection. That wasn't enough connection, honestly. So we all have advisees, and we have to make the effort to meet with them on a regular basis, even if it's every other week. And the agenda is, what do you want the agenda to be? Even if it's just talking and sharing aspects of your life. So, my advisee is interested in emergency medicine. And so I send her on a Netflix run to look at all of the, reality shows around emergency medicine and shock trauma life in the ER. And some of those programs. So that level of connection is how we've actively sought that out. But we realized, I would say 7-8 months in, that we had to pay attention to it specifically.
And Dr. Washington, you specifically alluded to this in your presentation about this sort of psychological care and mental health care. What are you doing proactively to identify people who might be having problems where they need help rather than waiting for them to identify themselves?
Can you hear me now?
Yes, we can.
Okay. One of the things that we've found is that we have to really pay more attention both to the residents and the medical students. To this end, we've developed programs, or when I say programs, a type of program where the students are required and the residents are required to meet with an individual and just go over the issues and the way they're feeling. And this is not really a resident evaluation interview as much as it's an interview for people to maybe self-identify that they're having issues that maybe they didn't realize, or piggyback on somebody else's feelings. And then we have a person available who is trained to discuss the issues and try to ferret out if there's more of a problem. In our medical students, we can send them to specific places for them to get more help, if necessary, at a higher level, either psychological or psychological, social, whatever it takes. So they can be identified and started on some sort of mitigation prior to them getting really seriously involved. Obviously, the other thing that we look for is a change in the way somebody's performing. If they've been an A student and all of a sudden they're not, or they're not showing up to class, or they're not finishing their assignments, these are some of the red flags. And the dean's office usually will start to, when this is reported, start to contact them to show them where there are resources they can go to in case they need help.
Thank you. Dr. Adams, any experience with this at Meharry? And again, you just need to unmute yourself.
By your picture.
There we go. We do have a number of services that we continue to use throughout the academic program. But one of the things that did decide to do was actually try to tackle some of the issues based on. So we did some poll questioning. We do poll questioning during the orientation. We have actually increased the number of times we do clerkship evaluation with the students. And we go through, a system of checklists of questions, both what are they doing professionally, but also what issues they're running into, and actually specifically ask certain questions to make sure there are no problems. They seem to they still seem to have the same frequent complaints. Actually, when they're not seeing cases as often, or if they're being pulled from case, they complain more about that than the fact that they are restricted from seeing COVID patients on one campus and expected to see COVID patients on another campus, like in Detroit. If they're really busy and they have, testing requirements, they seem to bring those to bear more frequently. But we have talked to them about preparation for residency application in the junior clerkship, the expectation that not only is it going to be virtual and not as three-dimensional and familial, but also that it may be recorded and reviewed by other individuals, And we have to talk to them about, how to set up production. We do spend more time talking with them about career and trying to make sure that if we're sensing anybody has sort of a change in their perspective because of this, we also kind of share we're encouraging faculty to share their experiences, like what was going on when I was resident with hepatitis and when HIV was only acquired immune deficiency syndrome, and the survivability through those processes and how things are going. We do also kind of reflect with them that they are novices and not to assume that they're being left unsupervised, but also letting them know that their faculty maintain safety, they maintain their health, even while we have different fluctuations. As a general rule, we have been successful in doing that. And we really encourage them to be vigilant and pay attention as they go to different sites on how to maintain your safety and not assume that it's okay to be laxed in the hallway or if they see someone else doing something that's not part of the policy. So we've done that. We've also increased our number of clerkship meetings with the other disciplines. And we've really requested there be more transparency so that we can know when one individual who's coming to our rotation has had some difficulties, so we can subtly direct special attention to that individual.
And I see in the chat that Dr. Wilson, who brought up this question initially, has organized peer ombudsman. And hopefully, Dr. Wilson will ask you to maybe send us some more information about that so we can get it on the website and get it out to all the attendees, because that sounds like a very innovative program. Dr. Sutton,
Oh yeah, I've already asked. I was like, doing that, help me.
Yeah, exactly. So I think, we've got some interesting ideas in the chat, and I will reach out to Dr. Wilson specifically and see if we can get some more information about that program. Another back and forth in the chat that seems to be emerging is some disagreement about the effectiveness of the remote and virtual interview process. And it seemed as though, Erica, Dr. Sutton, you had said that you felt that there was some leveling of the playing field, but that the same 100 applicants were being interviewed. Maybe you can elaborate a little bit on that.
Well, the first time we do something, like with many things in the pandemic, we might not do it perfectly. And so I think that having a virtual platform for interviews is going to reduce the cost for medical students. It's going to reduce, and who are applying for residency, it's going to reduce the cost for, undergraduate students who are applying for medical school. That is a good thing. It means that you don't have to have, $4,000 anymore to apply to a wide range of programs. I think what we'll have to do better is we'll have to practice that selection process. We'll have to practice how we don't all interview the same, 120, 150 candidates. They're all the same because they are strong applicants, and we all want to recruit them to our program. I don't think it's a reason to abandon virtual interviews, but I do think it's a reason to innovate through it. Dr. Williams has put in there, it's not about cost. The issue is access. So I certainly would encourage him to, elaborate further so that we have all sides of the discussion.
Well, and I think this access issue may be something that existed prior to us being forced to do virtual or remote interviews. So how do we identify, since this is a webinar being sponsored by the surgical section, how are we now going to identify people to make sure that we do have a diverse interview pool? Dr. Adams, Dr. Washington, any ideas on that to make sure that we are seeking out people who would not normally get interviewed? And I would say that problem actually predates the issue of access, predates it, but I would welcome your comments.
It does, and it does predate the pandemic, but We used to supplement that by having students rotate through selected institutions. We would help them choose, and we would network with the program directors and chairs. It's going to be a problem. This now individuals are, going to be less willing to take a risk. They're going to be more likely to go with what's comfortable. And if the National Board of Medical Examiners doesn't allow you to have, an objective assessment by going to pass or fail status, that's going to create even more of a dilemma. For me, it's a dilemma. I don't know what the answer is going to be. I do think that it's helpful for programs to record. Therefore, the program director has an opportunity to be able to view all the candidates, and the committee has a chance to see all the candidates versus the interviews that are not recorded, that are still just dependent on the summation of the interview.
Okay, Dr. Washington, any
Yes.
additional comments?
Yeah, just as a comment, I personally don't like the virtual platforms. I personally like to meet people, face to face. I think the key in terms of allowing access is the evaluation beforehand. But as a former program director, I can tell you, once people get to the interviews, a playing field. Through, and we don't eliminate, at least in the past, we've tried not to eliminate just on the basis of scores, as you can do, or whatever. We look for candidates that might have other things, and then we bring them all in. And then when you get there, it's your opportunity to sell yourself. And that's why I don't like this virtual as much. I don't think you have, I think if you have something to show, it's harder to show virtually than it would be in person as you interact with a lot of people who are interviewing you. That's my opinion on it.
And do you think that this is a result of what Erica was saying, was that it's because this is new to us and that we'll get better at it with time?
It may be. It may quite well be, but at this point, my spider sensation, I'm very much better with somebody face to face with me. I can watch their movements as well as their head. I can see if I feel they're being honest in their response. For me, it's better face to face. It might change if we had to do this for an extended period.
Okay. And there's a great deal of back and forth in the chat. It's not clear, Dr. Adams, how converting to pass-fail actually affects the residency training and recruitment for the Step 1 scores. And Dr. Henry Tillman said that you also need to recognize the impact of virtual interviews on institutions. And Dr. Adams also put in something saying that competitive specialties and residencies may not include candidates if they struggle with virtual formats. And that, I think, is probably going to be up to us to make sure that that doesn't happen, that we don't end up getting our candidates excluded in that way. I'm going to break with protocol a bit and defer to one of our very senior members of the section, Dr. James McCoy, who wanted, even though he's not a speaker tonight, I think we can give him some deference and allow him to, he wanted to make a comment about stress. Dr. McCoy.
Thank you, Dr. Joseph, and thank the presenters for very beautifully presented material. I wanted to make a couple of comments about stress. 4 months into the pandemic, the trauma service at Morehouse and Grady was experiencing an upsurge, not only with the virus, but with the trauma. And what Dr. Childs did was to reach out to the chair of psychiatry, and so that they had a grand rounds to talk about that and talk about how they could actually deal with the stress that the residents and the faculty was experiencing. And out of that, they actually formed a task force actually to look at that and to identify resources to do so. So that's one. And the second comment I'd like to make is that Dr. Sutton mentioned that we have the learning communities for all the students. It's principally for the first, second, and third year students. But in those learning communities, clearly the pandemic has disconnected the engagement of the students first and second year with the faculty. And so so the learning communities does give them an opportunity to express their emotional discomfort and the stress that they're experiencing. And so we encourage them during that time to continue to talk about that. We invite one of our faculty person does tremendous job with the meditation. And so we arrange for the meditation to take place on a wider basis, as well as not only for the students and the residents, but also for the faculty. So thank you, Dr. Joseph.
Thank you, Dr. McCoy. And may I just say personally and on behalf of the section, what a pleasure it is to see you on the call. Thank you. In the interest of time, I'm just going to just make sure everyone has seen some of the other comments that programs are not going to expand their reach to diversify unless we as faculty don't really push. And Dr. Sutton also said on the chat that students who struggle with virtual format are definitely at a disadvantage, and maybe this is an opportunity. We, both SBAS and the surgical section, are looking at partnering in a mentorship way with the Student National Medical Association, and maybe this is a project that we do with them to help train them about how to do effective virtual interviewing. Maybe this is a potential project. So again, I want to thank all of the speakers, Dr. Washington, Dr. Adams, and Dr. Sutton, for these wonderful presentations and for the education that you've given all of us. Certainly there's a whole lot more that needs to be said, and I wish we had more time, but please, everyone should feel free. I'll give the information at the end of the program, but everyone should feel free to communicate with us in the section and get this information out to us. If you have programs that are working, we have a way that we can get this information out to the membership. So I would encourage that.